I would now request our chairperson, Dr. Kiran Shah, to introduce our next speaker.
Moving ahead with this next topic, that is looking back and looking forward. That is looking back, what we have learned so far, and looking forward, what more we can learn and what more should we learn. And the speaker is none other than Dr. Manoj Chadha. He is MBBS MD, General Medicine and DM Endocrinologist from Mumbai. He is already attached with the Bangalore Diabetes Hospital, and he is a senior endocrinologist and diabetes. Over to Dr. Manoj Chadha.
Good afternoon, friends. It's a pleasure to be with this group. We've known Mayur Bhai for a long time. And this time he's given me a topic which has foxed me, because I'm supposed to speak on what have we learned till now and what do we still need to learn. So it's a very wide, abstract topic. So what I have done is put some of my thoughts in slides, and I hope we'll have some discussion at the end of this session. I have no financial disclosures for this talk. So let's begin by just enumerating the points that I'll be talking upon. And it's going to be sort of an overview of our knowledge about diabetes mellitus in terms of defining it, the new classification, the epidemiology, pathogenesis of diabetes. Focus is going to be more on the type 2 diabetes, a little bit about the metabolic effects and the legacy effect. Terms of complications of diabetes, what are we aware of? I had planned to speak on hyperglycemia also in pregnancy, but I guess you're going to have talks on this in the program, so I'm going to skip over it. The last part is going to be on CV outcome trials and what our guidelines say in terms of management. So the important part to understand is that diabetes is not high sugar, but it's a metabolic disorder involving the carbohydrate, protein, and fat metabolism. It is characterized by chronic hyperglycemia. So one glucose reading is not enough to say diabetes. It's characterized by absolute or relative hypoinsulinemia. Again, trying to say that there are two broad types of diabetes, type 1 and type 2. But the important thing is there are specific microvascular complications which occur in diabetics, which are different from the macrovascular complications which can occur in anybody. The last 1 year, you've seen a change to some minor extent from WHO, where they have kept the type 1 and type 2 diabetes classification, and they've looked at the lean patient, the obese patient, and the normal weight type 2 diabetics. I'm not going to go into too much of details, but the important part is in deciding the therapy that you want to give for your patients, this classification may be probably better than what was being discussed earlier. Huge number of patients, and every time IDF comes out with a estimate of what is going to happen in the next 15, 20 years, they turn out to be wrong because we reached those figures about a decade earlier. And the important part is that for every diabetic, there is at least one diabetic which is missed out. The diagnosis has not been made. So if you're talking of about 70 million diabetics in India over the age of 20, then probably you are looking at another 50% more. In addition, it remains one of the leading causes of death globally, along with ischemic heart disease, stroke, cancer, etc. So the morbidity is huge, the mortality is huge, and there is a death occurring every 8 seconds. In terms of the pathogenesis of type 2 diabetes, we have gone through the triple cause of insulin resistance, beta cell dysfunction, and then going on to the ominous update, and which probably everyone is very familiar with, but I just wanted to stress how our knowledge has improved in the last 2 decades. And today we are talking of 12 defects. The important part is that each one of these defects is now being targeted by therapy, so that hopefully our control of diabetes will improve. In addition, when we are talking in terms of pathogenesis of the diabetes, and the vascular defects that also exist with it. So hypertension and the coronary artery disease, strokes, peripheral artery disease, you find that there is a common soil theory where glucotoxicity, lipotoxicity, the inflammatory responses all lead to endothelial dysfunction and worsening of the insulin resistance, and thus leading to these multiple disorders together. I love this slide because it tells you that you need to work aggressively at the beginning when the patient is still fine, asymptomatic, without any morbidity, and has a long life to live. Unfortunately, what happens is we take things at easy. The patient is also relaxed. Oh, I have mild diabetes, I have a long way to go. But by the time we reach a stage of complications, it's probably too late. And we have seen that from ACCORD and ADVANCE, that trying to get aggressive at a later stage is actually counterproductive. So remember the legacy effect and the metabolic memory from UKPDS and DCCT. 2008 onwards, there's been a lot of emphasis on cardiovascular safety of the anti-diabetics. After the saga of rosiglitazone, US FDA made it mandatory that you must show that the drug is not harmful to the heart. It is as good or not inferior to placebo. And things went on from 2008 to 2015 that most of the drugs turned out to be non-inferior to placebo. It was after 2015 that the excitement started when we realized that the drug, starting with Empareg, was actually reducing cardiovascular mortality. It was reducing the 3-point MACE. And this was also seen in the CANVAS with anagliflozin, in the DECLARE with dapagliflozin, and further more studies that have come out. So a large part of it seems to be a class effect, and then there are some differences between each one, which probably becomes a theme for another conference. But the important part that I want to stress that came out of the SGLT2 trial specifically, and now even with the GLP-1 receptor analogs, is that it is not only good for glycemic control, it also reduces the progression of renal dysfunction. It actually can improve renal function besides the protective effect on the heart. We've always learned about the bugbears of intensive treatment. One of them is weight gain, and the second one, probably more serious, is hypoglycemia. The risk of hypoglycemia may be about 3 times higher when you compare it with the conventional treatment. But in terms of reducing the risk of complications, improving quality of life, and further reducing healthcare costs, probably the small increase of risk of hypoglycemia is worth it. We are always looking at therapies where the risk of hypoglycemia would be less. So the anti-hyperglycemic drugs or the newer insulins where the risk of severe hypoglycemia and nocturnal hypoglycemia is less than the conventional insulins. So I was talking about hypoglycemia, and if there is hypoglycemia, then probably the cardiovascular events, the microvascular events, all-cause deaths do tend to increase. So you have to sort of ride the gap between the two, high control and low glucose values. The UKPDS has been something like our Bible or Gita, and it has told us something very interesting, that when the diabetics progress into micro to macroalbuminuria, they actually are going about 2% per year in progression from nephropathy to albuminuria to end-stage renal disease. But the important thing is that about the same number or even more every year are actually dying because of cardiovascular disease. And by the time they reach end-stage renal disease, they have a mortality of 20%. So the important part in this slide is not the progression to renal failure, but the cardiovascular death that increases in these patients. Again, emphasizing go aggressive at the beginning when these patients are still healthy. We've looked at drugs to reduce the complications, reduce the progression of complications, and the RAS blockade has been around for nearly 2 decades. But this heat chart, which tells you how albuminuria reduces even at the cost of the GFR going down with the RAS blockade. It is still worth it because a patient on this side has a lesser risk of progression of renal failure than a patient who's on this side. So please remember this, that with the RAS blockade, a GFR reduction is possible, but it's not really harmful. The other thing which has really improved in this last decade or so has been the concept of continuous glucose monitoring. SMBG has been around, but for various reasons, the multiple pricks, the cost of therapy is not very popular. But with the continuous glucose monitoring, you get a proper video picture of what is happening versus a snapshot with 2 or 3 SMBG values. So you can get the highs and the lows, and there are multiple devices are available. The Freestyle Libra has just come into India, although Libra Pro has been around for a long time. Dexcom is not available in India, but pretty popular abroad. You've got the Guardian Connect, and then you've got the iPro 2. The important thing that has come out of CGM is this time in range. So you define the time range that you'd like to keep these patients to keep, say 80 to 140 or 160, and at least 75 to 80% of the day, that is about 17 to 18 hours, the patient should be in the time in range. As far as possible, no hypoglycemic episodes, and occasional surges with the meals is acceptable. So this is a concept which is being really pushed now. So I think we've been wiser. I've been a diabetologist for about 30 odd years, and I've seen a sea of change. But what do we still need to learn? Where are we lacking in our management and understanding of this disease? And these are the points I'd like to highlight on. Treating target, I'm going to give you some guidelines and where we stand. The important part we understand is that the beta cell dysfunction is progressive. So there should be some way of halting this progression. What are the newer drugs that we are looking at, and the importance of medications, control, blood pressure control, and reducing the complications. I'm not going to be touching much on this closed loop glucose monitoring system, but these are things of the future. And probably, hopefully, as we have gone into molecular biology, what can we do at the molecular level and genetic level in terms of manipulating the disease? So there are multiple guidelines that have been given to us in the last 2 decades, whether it is the AIDR, ESD, the ACE guidelines, the NICE guidelines, the IDF guidelines, now the RSSDI guidelines. The important thing I want to make here is we are looking at targets of 7% and 8%. But a couple of good studies from India and abroad have shown that our average control of patients in good clinics is about 8.5 to 8.9%. So what is the idea of talking of utopia when we are far away from reaching an A1C of 7%? So my first hope is to learn how we can manage our diabetic patients better so that we can get them to target. In terms, I said, looking at preserving beta cell function, there are multiple drugs being tried. They're looking at GLP-1 receptor analogs to improve beta cell function and preserve their function. There are a number of insulins that are there, the newer insulins that are coming. I think what is very exciting is the second generation basal insulins that are there in the market. They're getting frequently being used. But the third generation basal insulin, which you would be giving once a week, is something which is exciting. It is into phase 3, so it is not fiction, it is science, and probably another 2 years or so, you'll be using this in your patients. I have put this slide again, not because I have made a mistake, but like I said, I love this slide. I want to emphasize that we have been told, go aggressive from the beginning, so that the legacy effect can keep your patient going for a longer time, maybe another 2 decades, without any serious micro or macrovascular complications. And I hope that we learn this from our past, that we need to be aggressive. In terms of reducing complications, there are so many drugs in the market besides the standard anti-diabetic oral and insulins and GLP-1 receptor analogs. I'm not sure this list, how do they really work? What is the science and the data to talk in terms of reducing micro and macrovascular complications? But these are definitely good research for the future. And I hope that someone takes these couple of them for studying and what happens in terms of reducing complications. The last 2 or 3 slides, in terms of the manipulation at the genetic level, a lot of study has gone into the genomic structure. We understand that this is not a single chromosome defect that you can manipulate one chromosome, but the gene-wide analysis, the pharmacogenetics and pharmacodynamics of medications would be very useful. You will be able to do the genetics of a patient and decide whether he's going to respond to metformin, whether he's going to have side effects with metformin. Thiazolidine again, a drug which has fallen off by the side, but it is a useful drug. Will the patient gain weight with that? So these are examples of how pharmacogenetics may help you in deciding the type of medication to be prescribed. In addition, we understand that complications develop with time, with poor control. But then there are patients who present within the first few years with complications, and there are others who do well even after 25 years of poor control. So obviously there is a genetic component which we have to still learn about. Transplants in diabetes, in terms of the whole organ transplant, pancreas and kidney, have not become too popular because they're very difficult. They are expensive. We need the donors. So for whatever reasons, they never became very popular. The islet cell transplants probably was a feasibility, being done in developed centers in developed countries, but again, very expensive and not available to the general public. About a decade ago, I myself got involved in a project of xenotransplantation. They were looking at harvesting porcine newborn islet cells. So this project actually started in New Zealand, went to Russia, then was taken up in Mexico. And from the last I read, there is a couple of groups in the US which are looking at it. Very interesting, because you could then have an unlimited supply of islet cells. And from what I remember with the Mexican group and the New Zealand group was, you did not need the amount of immune suppression that you now need for the islet cell or the whole organ population transplantation. So this is something very exciting for the future. I thought it would be a good idea to dedicate this talk to these gentlemen who 100 years ago, a century ago, were responsible for discovering insulin and making a major change in the life of our patients. Probably they never realized their contribution, but today when we look back, it was fantastic that what they did about 100 years ago. So I'd like to summarize that diabetes is a huge problem. Our understanding has increased in leaps and bounds over the last, say, 3 to 4 decades in terms of understanding pathogenesis, in terms of understanding the therapeutic drugs that are available, the oral antidiabetics, insulin, GLP-1 receptor analogs. But we still have to get our patients to decent control. And like I said, probably we still need to learn how to control our diabetic patients, how to use the guidelines to the best for our patients, what are the new drugs that may be available with lesser risk of hypoglycemia, probably in combination with the standard drugs that are available, the newer options for controlling complications, and as I mentioned in the end, genetic manipulations and transplantations would help make our patients live comfortable and longer, and this scourge of diabetes would be much reduced. Thank you very much for your patient hearing.
Thank you so much, Dr. Manoj, sir.